and welcome to Digest This, where we discuss day-to-day clinical issues in gastroenterology. My name is Francesca Moroni. I am one of the gastroenterology trainees in the north of Scotland. Today we are discussing irritable bowel syndrome. I am delighted to welcome Dr Maria Eugenicos, a senior lecturer at the University of Edinburgh and Western General Hospital. Welcome, Dr Eugenicos, and thank you for joining us today.
Thank you for inviting me.
Functional gastrointestinal disorder, and in particular irritable bowel syndrome, make up a very large proportion of referral to gastroenterology clinic. But how we do define irritable bowel syndrome?
Irritable bowel syndrome is a prototype of a series of functional lower gastrointestinal disorders and is defined by repeated persistent abdominal pain, which is associated with bowel dysfunction. This can be either diarrhea, constipation, associated with bloatedness. It has to be there for at least 3 months in order to make the diagnosis, because any one of us could develop abdominal pain and irritable bowel habit at any stage of our lives.
General gastroenterology in the hospital really only see the tip of the iceberg. So what is the actual prevalence of this condition?
The prevalence of this condition in UK and North America is about 20-22%. We know that only 1 to 5% would attend a specialist clinic in the hospital, and about 5 to 10% may attend their general practitioner to ask for advice at some stage in their lives. The majority of these people, though, may have only mild symptoms, and they may opt out to perhaps treat their symptoms themselves.
And how do they commonly present to clinic?
Usually they may present with persistent abdominal pain that has not responded to treatment they have had by their general practitioner, or they may have troublesome constipation or diarrhea that again has not responded to the usual medicines. And some of the people may be admitted to the hospital, and then we discover that they have had symptoms ongoing for some time, but their symptoms, depending on several events in their lifestyle, they may become worse, and that leads them into attending either the hospital or their practitioner.
Is there a group of patients that may be more likely to develop symptoms in terms of age group or gender?
The common age that people may develop symptoms is usually their working life from 20 years to 60, and this make up the vast majority of patients with irritable bowel syndrome.
And so this must have an impact on their working time, on society, and potentially financially on the NHS. So how much does this cost?
It is quite costly. When we last looked at how many admissions or what is the proportion of these patients seeking medical advice, and is comparable to chronic obstructive airways disease, to congestive heart failure. And these people would miss more often days of work. 1 in 5 would call in absence because of health issues. So it does cause a big problem about cost in the NHS.
So when we have a patient at the clinic, how do we confidently make a positive diagnosis of irritable bowel syndrome?
We have now very good criteria, the Rome criteria, and we are up to the Rome 4 criteria that defines that if a patient presents with persistent abdominal pain for at least 3 months, which is associated with altered bowel habit, then you can confidently make the diagnosis of irritable bowel syndrome. There are basic tests, of course, we may need to do to exclude common conditions or simple conditions, usually full blood count. We may need to do the celiac antibodies to make sure somebody has not a celiac disease, does not have a celiac disease. And of course, we do the stool test for infection, the fecal calprotectin in those patients who present with IBS diarrhea.
And why is this important? Why is it important to make a positive diagnosis?
Making a positive diagnosis would help present a management plan for both the patient to know their condition and the treating management physician to lead to this patient regaining control of their symptoms and regaining their active life and a good quality of life, which may not have up until they present to the clinic.
So what option do we have to treat patients with irritable bowel syndrome?
These days we have very good options, we have good medicines, but we have good alternative ways of treating and empowering the patient to be in control of their symptoms and be discharged from the clinic. And first of all, I would stress out that these patients do not need to be coming back and forth to the hospital. I would advise that we avoid repeating tests because in that way we reinforce to the patient that we suspect there is something more sinister wrong. It's important to warn my patients that certain events in their lives, they make their symptoms become worse. In females, for example, sometimes during hormonal changes around their period times, their symptoms may become worse. If they know to increase or decrease the medications they take, that would be helpful. Stressful events, infections that they may have like any other person, that again may exacerbate their symptoms. They need to know how to control the symptoms during this particular time.
Could you give us a run-through on particular medication that we could use?
I usually start with simple things like bulk foaming agents, especially for those patients who may present with, let's say, diarrhea and incontinence. We do not want to constipate them. What we want to do is to improve their rectal sensation and improve their emptying of their bowels. The medication I would choose is methylcellulose, the Celevac tablets, because they can titrate the dose. They don't need to start straight away on a high dose, and that would sometimes make their symptoms worse. Other medications, depending if the patient presents with IBS diarrhea, commonly we would give a small dose of loperamide. If we can control the diarrhea symptoms, usually people will not experience worse urgency or incontinence. If they don't respond to that, some of the patients may go on codeine. Very few of them, because codeine has got an addiction problem there. On the other hand, there are newer medications like ondansetron. At present, what I would like and would ask all of you to do is not to prescribe the ondansetron. We are running a big study, a big trial, about 10 centers in UK, and our center in Edinburgh is one of them. We tried to recruit these patients to try the ondansetron. It's a double-blind controlled trial, and we want to know how does the ondansetron help the patients with IBS diarrhea. And one of the exclusion criteria is if the patient has had ondansetron before. So please, if you do have patients, refer them over and we'll recruit them for the study. For the now IBS constipation patients, I would start with osmotic laxatives, and again, we would titrate the dose. So do not cause them diarrhea. Some people may present with overflow diarrhea. So taking a thorough history examination would perhaps allow you to make a confident diagnosis that this is what we are dealing with. If the osmotic laxatives are not helpful, in Scotland we are lucky that we have the linaclotide, which is a guanylate cyclase C receptor agonist that has been licensed and is approved for use in IBS constipation. That helps abdominal pain, bloatedness, as well as the constipation symptoms. In England, they have prucalopride, which is for chronic constipation, is not though licensed for the IBS constipation. So some people may consider it not perhaps to be the first choice appropriate as a second-line treatment. Having said that all of these medications is fine, we should always address the lifestyle changes. I always go through the diet with the patient. I encourage them to drink water, physical activity, as well as ritualization of bowel habits that would make the patient confident if they move their bowels on a regular basis, that they can go out, they can sit in a meeting, in a conference like this, without the fear that they may experience urgency and they may need to interrupt their meetings and rush to the toilet. The other important thing is perhaps to inform the patient that certain food may cause worse symptoms and how to identify food intolerances. We are aware of the low FODMAP diet, although this is very restrictive, but I think the NICE guideline diet is as good, and in the studies is showed to be as good and comparable to the low FODMAP diet. Other than the diet, perhaps there are other ways of allowing the patient to be in control of their symptoms, especially stressful situations. And this would be meditation, relaxation, exercises, and others.
And so is IBS all in the patient head? And what is the pathophysiology of this condition?
IBS is not in our heads the way most people perceive it to be. Of course, there is an influence the way we feel, how our bowel motility happens, and most people would have an experience when they go for exams, for example, or for interviews, that they may get urgency or may get diarrhea. That's a normal reaction. As we mentioned earlier on in our conversation, Francesca, is that the IBS is not defined by any structural or pathological process, but there is physiological abnormalities that we can detect through motility studies. So we can demonstrate at certain times that these patients may have slow transit, or this patient may have an unduly response to certain stimuli. Like patients may have visceral hypersensitivity and they experience pain when you and I may not experience pain. Or they may experience the urgency when you and I do not have these symptoms. So certainly it's not in their head, in that sort of perception, but how our body and our mood and our brain perceives certain way, it would influence our bowel motility.
And so this is about the gut-brain interaction. And what about short or long reflexes in the gut or gut microbiotas? Do they have an influence on the pathophysiology of irritable bowel syndrome?
So you have touched a few things now. The gut-brain interaction, as you mentioned it, has allowed us to study certain ways of dealing with these symptoms because there are conscious and unconscious ways, as well as hormonal influences on these circuits. And through the conscious way, we use biofeedback treatment for retraining. The unconscious way, we know that certain events might influence these people. Stressful, traumatic experiences, especially in childhood, may allow people to develop these symptoms. And this again where we would go on to cognitive behavioral therapies. So try to use the deficient skills, if I may say so, of patients who develop IBS, how to use them and how to retrain them in order to correct these inputs. Secondly, other than the cognitive behavioral therapies, the biofeedback that we use in Edinburgh, we can allow them to have relaxation therapy and meditations. There was a large study on hypnotherapy, for example, in Manchester under Professor Waldwell, that showed that these people, if they offered hypnotherapy, they do better, especially in pain control. And of course, we touched about medications regulating the bowel habits, but we haven't touched about medications about the pain, which is sometimes the most stressful symptoms for these patients. So antispasmodics have very limited effect on these patients, although we would encourage perhaps the colleagues in general practice to start with perhaps mebeverine or Buscopan that has been shown to be superior to mebeverine in certain studies. A low dose of tricyclic antidepressants, like we use in every other chronic pain. Some of my colleagues would avoid treating them with tricyclic antidepressants, so this is where SSRIs may be helpful, like fluoxetine. Another question you raised, if you remind me?
The short and long reflexes?
Yes. I always explain to the patients about the reflexes that we use, and the most known to everybody is the gastrocolic reflex. And it's the reflex that we use for potty training. And the reason we use that is because the gastric sensors would stimulate the bowel motility in a physiological way. So as soon as food enters the stomach, and this is how I explain it to the patients because I try to get them engaged in their education and empower them in that way, would stimulate the bowel motility. Now, if the bowel is empty, as we would usually have as adults, because we empty our bowels on a regular basis, then people will not experience anything. So as we grow older, this reflex dies down. But in patients with IBS, this reflex is very active because their bowel is not as regulated as one would wish to have. So these people may experience abdominal pain or they may experience urgency while they are eating. Is not what they are eating, is what the bowel already has there and may not be able to catch up. Another reflex that is very important is the enterogastric reflex now. When the bowel is not functioning properly, it feedbacks to the stomach, telling that I am not ready and I cannot be ready, if you like, in a late terms. So the stomach may delay the emptying because of that. And as a result, keeps producing acid to help the digestion, and these people may experience worsening heartburn and may think they have delayed emptying with early satiety symptoms, but usually when we control the bowels, these symptoms subside.
Would you like to comment on gut barrier and microbiota as a role in irritable bowel syndrome?
Certainly. There have been very good studies that showed that altered microbiota would lead to irritable bowel syndrome. And the good model that we have studied is a post-infectious diarrhea model of development of IBS, where we gather that there may be a genetic predisposition who develops IBS in the presence of stressful situations at the time of an infectious stimuli would alter the microbiota as a result, would alter the mucosal barrier, allow a leaky, if you like, mucosal barrier, and that would lead to post-infectious IBS. So it's a combination of things rather than one or another factor, because not everybody who has infection develops IBS, but there are certain people who might do, and these people usually might give us a hint that at the time they may have been depressed or they may have been anxious or going through stressful situations. There have been again studies that showed that probiotics or prebiotics are very helpful in controlling, not just restoring the microbiota, but controlling the symptoms of IBS. And I would usually encourage people to take that. We do not prescribe any probiotics these days. These are usually considered as food supplements, so I would encourage my patients to take probiotics and allow symptoms control through that. So it's a very healthy way of dealing with symptoms.
General gastroenterologists can find challenging treating patients with irritable bowel syndrome, but how can we improve patient outcomes?
The difficulty that general gastroenterologists have in dealing and treating these patients is firstly because we have not included the functional GI disorders into the trainees' curriculum. This is what we are trying to address. We do appreciate it's very important to train people in treating patients with inflammatory bowel disease, train people in various subspecialties like hepatology. But on the other hand, we have to appreciate that the majority of the patients that a general gastroenterologist would see would be patients with functional disorders. Part of our failure in allowing the training in functional GI disorders to come into the curriculum is because up until now we did not have very good structured or perhaps ways of dealing and examining and studying these patients, whereas now we are much better in that. So we do like to encourage people to perhaps do some research, spend some time in the GI physiology laboratories to come into contact with these patients so they empower themselves in how to treat these patients further. I would like to stress once again that the diagnosis of IBS should be made through detailed questioning and examination, clinical examination, limited investigations, and of course, spend time in educating our patients and how to empower them. And this would be perhaps our strongest ace of how to deal with these problems in the future. We have spent quite a long time in Edinburgh doing studies looking at how these patients are approached. And we have done a recent study and published it on patient empowerment. And this is what the patients are looking for. This is what my colleagues would encourage. So we have now developed an educational booklet, which we would like to offer to our general practitioner colleagues and to the patients as well as to other gastroenterologists.
You touched briefly earlier on about abdominal pain being one of the key features in irritable bowel syndrome. And nowadays we observe a trend on overprescribing opiates. And we know some patients with functional gastrointestinal disease may be on long-term opiate analgesia. Is there a role for opiates and irritable bowel syndrome?
This is an easy answer, Francesca. From my point of view, there is no role of opiates in chronic pain in IBS, in irritable bowel syndrome. The new approach is that these patients do not respond to the opioid. And the opioid, of course, would cause other problems, as we know, in the bowel motility and would lead into perhaps chronic constipation secondary to the opioids, and that may lead to an overflow, diarrhea, and incontinence. So these patients may present with a complex syndrome then. What may have, though, is lack of response because of the opiates. So what we are planning to do in Edinburgh is to form a clinic where we would gather these people and try and titrate, withdraw the opioids from their routine, offer alternative pain relief, but not opioids, and perhaps address their bowel symptoms. So there is no role for opioids in the treatment of pain in irritable bowel syndrome.
Well, I am aware that you run a tertiary referral center for lower functional gastrointestinal disease. I just wonder if you would be able to give us a run through your clinic model.
As a development of that, we now run a joint GI, a psychiatric clinic once a month, and we see jointly patients with a consultant psychiatrist, a colleague who has an interest in the functional GI problems as well as the psychiatric issues. And we treat these people jointly. And we find that having audited our clinic, that these people would be rehabilitated and would respond to the GI treatment far more successfully as compared to not addressing their anxiety, depression symptoms.
And so to conclude, how can we improve patients' pathways, and what would be your recommendation to the gastroenterology that is going to see a patient with irritable bowel syndrome in his next clinic?
Educating your patient, building up a doctor-patient relationship, it's very important for the gastroenterologist as well as for the patient. Warn the patient this is a common condition, and that this happens about 1 in 5 adults, and women are more often suffering from this condition. Warn them that certain events in their life may make their symptoms worse, and empower them to know how to deal with these situations. Allow continuity. Do not discharge your patient straight on after you have offered them treatment. I will not advocate that you see your patient in 4 or 6 months' time, but I would say in 8 months or a year's time, allow the patient to come back to make sure that they do have improvement in their symptoms, and then discharge them over to the general practice. They do not need to be coming back and forth to a secondary care gastroenterology clinic. Taking a thorough history, making a thorough examination, explaining to their patient why do they have the symptoms they have. This part of their education and empowerment. It's important for the patient to understand why you're treating them the way you do, and in that way they would comply better with the treatment you offer them. Because we find that sometimes the patients do not comply to treatment because they do not understand why you treat them the way you do.
So all is left for me to say is to thank you for an excellent run through a very relevant topic, and to thank you for joining us today for Digest This.